Sige, Phil. I'll just start na, guys. Ha? So, if you have any questions, just feel free to interrupt my discussion, okay? So, I can't log into my second device. So, I can't see you guys. Ha? So, just, uh, just talk lang or just interrupt me when you have questions, okay? So, ophthalmologic examination. So, these are our resources for this lecture. So we have Rowan and Raspberry's General Ophthalmology. And these are equipment we use for our basic eye examinations. You have your charts, your jiggers, and for far, we have the Snellen, have a pen, we have our topical drops, and ophthalmoscope. We also have our pinhole. Okay, so to start, the eye is the most accessible to direct examination. For external anatomy, it's being inspected, and interiorly, we use more advanced instruments with the help of our slit lamp, and um, we quantify the visual function through these examinations. Guys, can you hear me?
Yes,
Yes,
Doc.
Doc.
Definitely.
So the only body part or blood vessels and the nervous system tissues can be viewed directly as the eye. So in ophthalmology, we rarely perform other examinations, but in one disease condition, we usually perform auscultation to the eye, where periorbital area. We auscultate there. We place the diaphragm of our stethoscope to listen for brewy. So does anybody know what specific condition I'm talking about? Wala. So in cases wherein you encounter cases na diagnosis is carotid cavernous fistula, those cases we usually hear brewy when we auscultate the periorbital area. So that's the only time we ophthalmologists use uh, our stethoscope. So that's the only time. So, but mostly we do inspection, and with the use of our advanced instruments and the slit lamp, we check the internal eye structures. Um, inspection. Mostly we do inspection for assessing the eye problems. So, slit lamp. So, have you seen slit lamps na? Guys, have you rotated in Soto? Not yet.
Not yet, Doc.
Not yet. So, soon you'll become junior clerks. So you will be familiarized with this material or equipment. No, so this is the slit lamp. We use this to examine our patients uh in ophthalmology. That's the very instrument. That's the very equipment that we use most of the time. So we start from the patient's history. So coming from the patient, we ask for their chief complaint, the duration, frequency, the intermittency, the rapidity of onset, the location, severity, and circumstances. So basically, we extract the patient's history or the HPI. Then we ask for the ocular history, specifically the medications instilled, current and past ocular disorders, if there is any, or the patient was diagnosed from other institution or from previous consult, past medical and family history. So your comorbidities, presence of other conditions, systemic medications, mga maintenance, any presence of drug allergies, history of eye trauma, surgery or contact lens wear, or any forms of refractive correction the patient had family history of blindness. Does the patient know any specific conditions such as your glaucoma, ocular tumor, retinal detachment, or patients with strabismus, or relatives with strabismus, or those eye with exotropia or esotropia, no, or those eye na um, banlag or libat in Bisaya. So evaluate visual complaints. So common ocular symptoms we are given with three basic categories. So abnormalities of vision, abnormalities of appearance, abnormalities of sensation. So for visual abnormalities, it's anywhere along the eye. So it could be from uh, outside or anteriorly from the adnexa, cornea, and up to the inside. So could be through the visual pathway involving your posterior segment, posterior structure such as your optic nerve going to the brain or chiasm, and then it's connected to the brain. The central acuity versus peripheral vision. The duration is also extracted, whether it's transient, acute, or chronic. So the degree of visual loss, we're also asking that for the patient, and presence of visual aberrations such as glare and halos, distortion, floaters, flashes of light, and diplopia. This could help you narrow down your differentials in assessing the patient's condition. So for the appearance, uh, we obviously see the appearance of the eye as the presenting problem sometimes. No, so if the patient has red eye, or if there are other abnormalities of color, such as in patients with liver problems, so we see jaundice. If other conditions, we have pigmentation or opacities. So can also see from external any lesions, tumors, presence of inflammation through the slit lamp. We can find it, we can check it through slit lamp examination. Presence of deformities and displacements, so you can see how it appears grossly. For your sensation, uh, does the patient feel any pain periocularly, ocularly, retrobulbar, or a patient poorly localizes the condition or complaint of pain. So some patients would just quantify it as dull, diffuse, or the patient cannot really tell you the specific location, but it's just there. Presence of irritation is there: dryness, itchiness, tearing or secretions, burning sensation, grittiness, or foreign body sensations. And sometimes your patient has just non-specific complaints. So those are your three basic categories, no, for your common ophtha complaints. So sensation, problems in appearance, and visual abnormalities. So far, are there any questions?
None so far, Doc.
Okay, so let's proceed. So going to the basic ophthalmologic examination, um, we have our VATEF. So do you know what VATEF means? Anyone? V is for, don't have idea, guys.
Alacrity, Doc.
Visual acuity. Wala, sige, sige. So somebody said visual acuity, no? So V is your visual acuity, A is for the adnexa, T is tonometry, E is extraocular motility, and F is your fundoscopy. So at your level, we expect you to be competent in performing this examination when you rotate in ophthalmology rotation. So when you become clerks someday, I hope this lecture would help you in performing that examination um, well. So for your vision, we usually treat this vision as the vital sign. In ophthalmology. This is our vital sign, the vision. It's measured in every ocular exam. So there's no case in ophthalmology that visual acuity is not being asked. So this is the most important. Okay, this would be our basis for the patient's management. So it's measured in every ocular exam, whether with glasses or not, quantify the visual acuity and visual fields, and then it's subjective, requires patient response. So it uh, it requires patient response, meaning if your patient is uncooperative, to have your your objective means in getting your visual acuity still, since it's a vital sign. There's no case, as I've said earlier, there's no case that visual acuity is not asked. No, so if the patient is uncooperative, like your patient is in coma, you still can assess whether the patient has visual function. Later, I'll be discussing that. So, with vision, you'll be having an intact neurologic pathway, structurally healthy eye, and proper focus. So, it's a measurement of the smallest object a person can identify at a given distance. So, it's tested both for far and near. So OD meaning oculus dexter for the right eye. That's the usual abbreviation we use. OS for left eye, OU for both eyes, SC without correction, CC with correction, corrected acuity. So we ask the patient to use a corrective device or glasses. So visual acuity is recorded as a fraction, and this compares the patient's performance with an agreed upon standard. So 2050, 2070, 2200, 10200, or 5200. That's the uh, visual fractions. No, so to 2020 to 2020 is the is the normal no visual acuity. So the numerator represents the distance between patient and the eye chart, and the denominator is the distance of the smallest row of letters that the patient can read, and distance at which a person with normal VA can read the letters. So if the numerator, since this is the patient's since this is the patient's distance between the eye chart, so this the number that you will record. So numerator is the distance that you will be recording if the patient is standing in front of the eye chart, while the denominator is the distance of the smallest row of letters. So later I'll show you the chart. So it's the last smallest row of letters the patient can read. So hantod sa asa lang iyahang makaya. So the distance at which in which a person with normal visual acuity can read those letters. So in this Snellen chart, for example, your patient, if your patient can read until the seventh line, so FELOPZD, so it's recorded as 2025. Now, so Snellen chart is the test distance is 20 feet. So the numerator, usually the distance of the chart from your patient is usually 20 feet. So we then write the denominator at which the patient can see the smallest letter, or the patient can read the smallest letter. So if the patient can only read until the second line, so we record it as 2100. Now if the patient can read more than half of that line, no, so this is another type of chart, the Bailey-Lovie chart. This is also used in some outpatient departments, and this also have their corresponding measurements at this area. It's small, you can't see. So in visual acuity testing, you test one eye at a time, and by convention, we start with the right eye first. So we read the smallest line with more than half letters or up to types distinguished. So if the patient, as I've said earlier, if the patient can read more than half, then we record that line as the patient's visual acuity. So if the patient, say for example, and the patient can only read, on the third line, the patient can only read TO. So since it's more than half already, so we record this as 2070 minus 1 since the patient did uh, read the last letter. So 2070 minus 1. So by using this chart, we can also consider the crowding effect. Crowding effect crowding effect your crowding effect uh, pertains to the effect of blurring. Some patients would see those letters, these lines, for example, since there are a lot of letters seen in a particular line, there is crowding, so there's visual acuity degradation. So they would complain blurring of vision as compared to if seeing just one letter in a line. So we have to consider that effect since it could give us falsely negative or result for visual acuity. So if the patient would normally read that letter, and then the patient just said that he can see blurred, he can see blurry, even if the patient can usually read that letter, no, so we consider crowding effect. So if VA is 2030 or less, we do pinhole. 2030 or less. So remember remember that we only we only do pinhole when the patient's VA is 2030 or less. 2020 or 2025, no need to do pinhole. Okay, so for visual acuity testing, we test those patients with glasses and without. If they have glasses, we test them with glasses and without glasses. So the one with SC and CC, we record it as that. So pinhole, we use this device. It has a hole on the cover, no, in the eye cover. So we let the patient uh, view or align his visual axis to that on dots. It estimates the corrected visual acuity and prevents misfocused light rays from entering the eye. So since the pinholes are directed to the patient's visual acuity, the light rays will be hitting directly onto the patient's retina. So only centrally aligned focus rays reach the retina and resulting in a sharper image. So this is how we that's how we ask the patient to use the occluder. So at first we place it in front of the patient and let the patient read the visual acuity chart with the right eye first. And if the patient's VA is 2030 or less, meaning 2030, 2040, 2070 up to the worst na visual acuity, visual acuities, we then perform the pinhole by just turning it down. than the picture in letter B. Okay. So if a patient can see the largest letter, meaning to say the patient can see the letter E, no? So it's the biggest letter that we have in our chart. We have to reduce the testing distance. And then we consider, since we consider the distance as our numerator, so we then adjust the numerator as the distance to where we adjusted. So for example, if we let the patient read the the chart at 10 feet instead of 20, then we have to record it as 10 over 200, of the patient. So the patient can see letter E at 10 feet, what a normal patient can see at a 20 feet, na 20, 200 dapat. No? So we just adjust the numerator to the distance, to where the distance between the patient and the chart. So unable, if the patient is unable to read at 3 feet, so that's the nearest na we can adjust our chart, to the patient. You can adjust it closer. You can reduce it by half by doing having 10 or 5 until 3. But if the patient still can't read at 3 feet, um, we then perform counting fingers. Now we check, we assess, we ask the patient, we present our fingers in front of the patient, and see if the patient can count how many fingers we are presenting in front. No, so if the patient can read or can tell you how much or how many fingers you are presenting, then record it as counting fingers or CF. If still the patient can read, can't can tell how many fingers you've been showing, by doing the counting fingers testing, test for hand motion. You wave uh, at some distance, like around mga 2 feet. No, you you wave, or you flash your hands in front of the patient. So normally, if the patient can appreciate any hand movement, record it as hand motion. But if the patient still couldn't appreciate any hand movement, you test for any presence of light appreciation or light perception. And um, if the patient can appreciate any light, you quantify the light by its projections. No, so you test the light upward, downward, and both left and right gazes. No, so for the light projection, if the patient can identify the light from all the directions, so it's recorded as good light projection. If the patient can only identify two to three directions, light coming from two to three directions, so it's just fair. So if the patient can can identify one light direction, it's recorded as poor light projection. So again, in visual acuity testing, we start with the distance na visual acuity testing by reading 20 feet from the chart. And then if the patient still couldn't read at 20 feet, we can divide the distance into half, or to a quarter, until uh, 3 feet, no? And then if still the patient can't read at 3 feet, we perform counting fingers. And if the patient cannot appreciate your or presence of fingers, no, it can't tell how many fingers you're presenting, then you do hand motion. If still no hand motion is appreciated, do light perception testing. And then you quantify it by doing some projections and you grade it as discussed earlier. So with good light projection, fair or poor. Then if still the patient couldn't appreciate any light, no, there's no light perception, so the patient's eye is totally blind na. So that's a time na he say that no light perception na since the patient can't appreciate any form of light in any direction. So that's the end na sa visual acuity sa patient. So wala siya makita. So these are your different types of charts. You have your Snellen, the HOTV. You have some optotypes, pictures, symbols, the LEA, the tumbling E chart, the C chart. No? So we usually for these figures and letters, we usually test this for illiterate or preschool, no, mga children at preschool. Then for adults, we usually use this HOTV and Snellen's chart, the A and B. So in recording your visual acuity, um, we start it we started testing with the right man, no? So we record it as follows, no? So if the patient has no glasses, we write it as SC without correction, and then 2025 for the right, and then with correction is 2020. So with the corrective glasses. And the left eye, without correction, it's 2050. We write an arrow going to 2030 if the patient's visual acuity is improved by pinhole. No, so when gali, uh, when do we perform pinhole? Yes, if the patient's PA is worse than 2030. Can do you follow? Hello?
Yes, Doc.
Oo. So we have to remember that ha. So every time as can observe, no, so the patient's visual acuity on the right is 2025, no, so no pinhole siya. So we only do perform pinhole if the patient's visual acuity is worse than 2030. So in this left eye, the patient's VA is 2050 at the beginning without correction. So we used pinhole and it improved to 2030. So with correction or with the glasses, 2040, and it proved with pinhole to 2020. So for visual acuity, such as your counting fingers and motion, it couldn't. It's there's no point of doing pinhole man. So just record it as is. No, so counting fingers, and if by pinhole testing, there's still no improvement. No, um, the patient if the patient can initially read at 2040, but when you did pinhole there's no improvement or no the patient's VA did not improve, so just record it as an IPH, so not improved with pinhole. So if the patient can no longer appreciate any counting fingers or can't identify hand motions, you check for the light perception. So light perception always paired with presence of projection. So light perception with good, fair, or poor projection, and then record it as is. No, so for visual acuity 15200, improved pinhole to 2100. So for the near visual acuity testing, uh, we use this chart na the Rosenbaum or the Jaeger chart. This is the one at the picture no. So it is performed if the patient has complaint about near vision, distance testing is difficult or impossible. So if the patient usually reads newspaper and then suddenly the patient would complain about not being able to read the newspaper na. So test for the jigger or the near vision. No, it is noted as the Jaeger notation here at the boxed part of the chart. So record it as J1 plus if the patient can read this so tiny numbers, and then up if the patient couldn't read this numbers, we then use this 95874 as J1 and 2. So, for example, the patient is 2025 without correction, and the patient can only read 638 for the right eye. So, record it as J10. And if with glasses, that patient improved to 2020, and the patient now can read until J7. So, meaning the patient can read 8745. For the left eye, 2050 initially without correction, improved by pinhole to 2025 J1. So meaning to say the patient was able to read the smallest numbers, no 4, 2, 6, 7, 3. Hindi na siya klaro. So, uh, so it's in children, it would be different since some children are difficult and uh, uncooperative. No, they are most of the time irritable in the examination area. So if there's no born, we just perform in presence of corneal light reflex by flashing pen light in front. No, we then test for pupillary function, check for the red reflex and fundus examination. For infants to 2 years old, we can assess visual function instead of acuity. Um, we usually perform CSM, or we record it as central, steady, or maintained. And if the patient can fixate and follow a certain target or an object that we introduce. For 2 to 5 years old, yes, we treat them as young adults na, no? So we test visual acuity like sa Snellen chart na, and then patients may not reach to the 20. It's okay. As long as the VA is equal in both eyes, no? So 2040 to 2050, it's okay pa for patients 2 to 5 years old. For nonverbal or pre-verbal children, usually do the CSM method, the central, steady, and maintained. If the patient uh, this is in relation to the corneal light reflex. No? So central, if the corneal light reflex is seen at the center of your pupil, so it's recorded as central. And the steadiness of the eye, we record it. If there's no presence of nystagmus, then we record it as steady. So for maintained, if the patient can maintain the fixation after removal of occlusion. So for this picture, the corneal light reflex is centered on the left. However, on the right, it's not right. The corneal light reflex is seen at the temporal na pupillary border. So the eye is deviated inward. Okay, so another example for this patient with nystagmus. So we record this as unsteady, and then for the non-central, then not maintained. So for patients with esotropia, like earlier, the eye is deviated inwards. The corneal light reflex is seen at the temporal side, no, of the eye. Then exotropia, the eye is the eye is deviated outward. So the corneal light reflex is seen nasal, no, nasa nasal na pupillary border. So we record it as ET for esotropia, and exotropia is XT. So if the patient has nystagmus, we usually use unsteady, so US, central or non-central, UM, or unmaintained. Okay, so maintained, if the patient is non-central, we just use ET or XT. For confrontation visual field, we test for any gross visual field defect. We test this at a distance of 1 meter or one arm's length from the patient. We cover one eye page over one eye at a we test for one eye at a time. And the examiner also covers the opposite eye to the eye being examined. We maintain the fixation on eyes and use counting fingers instead of finger movement. And we then test for 4 quadrants, seen in this picture. So we show our fingers at least twice, no, in the patients. Make sure that you can also um, see as well as the examiner. You can see your fingers, no. So um, you record if the patient cannot appreciate um, your finger, you can't see your finger, then you have to shade that area as shown in the second picture, no, sa middle. So the patient has bitemporal field loss, can't count your fingers at both temporal areas. Or for this bottom picture, the patient can't count your fingers on both na side na to right. So it's important na you can it's important that you can grossly check for any visual defect at this point pa lang, so that it would be helpful now when your resident or when a senior comes in for evaluation, no? So para the patient's examination would be hastened and the examination will not take long. For external examination, general examination of the anexa, we check for the eyelids, the globe, the orbit, lymph nodes, sinuses, the skin. And we perform it before evaluating the eye under magnification, or before we do the examination under the slit lamp. So we do gross inspection and palpation also for lesions, inflammation, and malposition asymmetry. So for palpation, we usually perform this if there's an obvious malformation, or there's presence of or presence of periorbital tumors. You can palpate it, and then yeah. So we check for asymmetry. So we check the gross picture of the patient's head as a whole. For the adnexa, we use pen light. No, check for the external adnexa. Check for the eyelids, the surrounding tissues, and the palpebral fissure. We palpate and the conjunctiva and check the sclera. No, and then for the upper eyelid eversion, we You just manually avert the eyelids and search for any presence of foreign body or conjunctival signs or presence of your follicles, papillary reaction, or other signs. Then topical anesthesia helps facilitate this examination as it would bring comfort to your patient. Doing so could give your patient a necessary discomfort man. So anesthesia can help in this exam. Okay, as you can see, the patient's upper eyelid is being everted in this exam. So it's important, na, especially if the patient complains of foreign body sensation. Also, it's important to check if there are any presence of foreign bodies lodged on that um, palpebral fissure. So this is an obvious na presence of ocular tumor or periorbital na mass. No, then it's as you look at it, it looks like cystic. So we can also perform transillumination test. So at at the examination, you can see the positive na transillumination test. So it's cystic. So for pupillary reaction testing, we usually note for the size and shape of the pupil. We also check for the direct and consensual reflex. And then most importantly, the presence of relative afferent pupillary defect or RAPD. Um, Presence of these tests, no, presence of positivities of this test may reveal indications of neurologic disease. So it's important to perform to assess your pupils also. So we have the swinging pen light test, no, to check for the presence of RAPD. So we do this by shining a light onto the right eye first, and then we check for both the direct and consensual reflex. Direct if you are checking for the right eye, and then you're flushing for the right eye also. You're checking for the reaction of the right pupil. So normally, if you shine a light on a pupil, it would constrict. So if the patient has normal direct reflex, so if you shine a light, normally it should constrict the pupil. And then for your consensual reflex, still flashing the light on the patient's right pupil, no, you observe for the consensual constriction of the other eye. So that's the normal na response. If you shine a light, the direct and consensual reflexes would constrict your eye. So normal in abnormal situations or in you note any presence of eye problem, so there would be observed na presence of positive or APD. No, so instead of being constricted for the direct na consensual reflex, when you transfer or you switch the light to the other eye, instead of constriction, it will dilate, no? As this picture show. So normally it should constrict man. So if the patient's eye would otherwise do dilate, no, so that eye is problematic. So you investigate further. So normally for your anterior chamber depth of the for the anterior chamber, you check for the anterior chamber if it's deep, no, and if the iris is flat, if the iris has flat contour. If the AC on the anterior chamber is shallow, your iris would be bent forward. And if nasal iris is seen and the shadow and light is directed on temporal side, so that's why it's important to use your pen light, no, so you can appreciate it by shining pen light the side of the patient. So at this in this picture, you can appreciate you can appreciate the depth of your anterior chamber by shining a light at the side of the patient. So you can appreciate the depth of the anterior chamber like this. So normally you can see the light. Uh, you can see the light traverse until the other side, no, the opposite side. However, in patients with shallow anterior chamber, such areas at the opposite end would uh, be covered in shadow. You know? So that's how we tell if the anterior chamber is shallow or deep. Then how to draw? Usually, we're not expecting you to draw it beautifully, you know, but uh, basically it would contain the important details that we are looking for. So we usually ask you to draw these structures for both eyes. No? So the semicircles or the this pertains to the eyes, the lids of the patient, the upper and the lower lids, and then the opened eye wherein you can see the cornea and you can see the limbus or the entire cornea, and then uh, this is the pupil, and then can see the upper na lid na being for this picture we use this when the eye is everted. So if we when we avert the eye and then we saw a foreign body like this, when we draw this dot no here, so it would mean that we saw or we recorded a foreign body on the patient's upper palpebral conjunctiva. So for this one, the inferior, when we retracted it, we also record our findings here. Then we just yeah. For the X, no, we usually usually use that for the corneal light reflex. So if it's center, so we use the X, we place the X at the center, and right if the pupillary reaction is brisk or um, sluggish, then usually also record it as deep. If we shine a light at the side of the patient, now we can assess it if it's deep or shallow anterior chamber. So if also during our swinging flashlight test, we recorded a positive RPD, so we have to record a positive RAPD to which eye that we observed the abnormality. Okay, RAPD, your RAPD is a unilateral finding. No? You can't appreciate RAPD on both eyes unless your both eyes are affected equally. So most of the time, there has to be an eye that is affected more, or there's only one eye being affected for you to appreciate our APD. So yun, drawing niya metallic foreign body. So for this one, how would you describe this one? Any volunteer? Wala, no? So if you'll be checking this patient, you just draw how you see the patient, no? So record if you inverted the eyelids, and then no pertinent findings seen, just can you can just cross that, make that line there, and then just record or draw the nodule with a central na pass. Okay. So for this, after everting, you notice this presence of conjunctival reaction. Now you have to describe what you see. So these are rough edematastarsal conjunctiva with giant papillae. So these are your giant papillae. No, they are conjunctival reaction to any other offending agent. So it could be from medicine, could be an allergic reaction, could be a foreign body. No, so it's important to avert your eyelids. So, but you you really don't have to draw it as uh, artistic as possible. No, it just has to be complete with the details that are being the details that are important in our documentation. So if you see giant papillae, you just draw large circles and the everted eyelid. And then if the patient has floppy um, lids, you can just extend or just draw as that. So there are lots of variations or deviations from the normal. No? So you can just do your best in illustrating what you see. No, so for this patient has red eye. No, so you can just make use of whatever red ink you have to cover to color that area as red. And then for the discharge here, you can see the pus lodge or the inferior na eyelid, and then cover some of your lashes. No? So you can just draw, or using a yellow color, you can just draw pus inferiorly. And then when you everted the eyelid, you see follicles or any reaction, conjunctival injection. Just you can just draw uh, dilated vessels, or just exactly illustrate what you see. So it's important that we know that you you have seen the important details, in checking the patient's eye. And then don't forget to label your drawings. So this picture, you can see that the discharge is being labeled as yellow mucoid discharge, based on this picture. So we can appreciate the yellow mucoid discharge, and then the conjunctival redness also, dilated vessels. For the pupils, not all the time your pupils are round. No, so it's important that you also record the shape of your pupil. So if the patient is like this in picture, it's like a teardrop. No? So you draw it as is. It's not all the time again. Your pupils are round. No? So just copy what you see, or just draw how you see the patient's examination. Examining the patient's eye, just draw what you see. It could also be in a heart shape. No? Some patients with posterior synechia, As you can see, the patient has some adhesions here sa iyahang pupil, ay sa iyahang iris. Patient has adhesions to the lens. So giving that shape, no, heart shape when the patient's eye is dilated. It did dilate fully. Some of its areas are adherent to the anterior capsule sa lens. So this, when you draw a patient's pupil, now you also have to approximate the size of the pupil. For this patient on the right eye, since the patient's right eye is seen like a pharmacologically dilated eye na, so you just have to draw a dilated eye, just label it lang. And then note any presence of opacities. No? So at this in this picture, it's labeled as central lens opacity. And we just mimic or we just draw what we see. No? So there is a central lens opacity. And then compared to this picture on the left eye, it covers the entire pupillary aperture. No? So the lens is already white. So we label it as white lens opacity. As you can see, we don't use the word cataract here since because uh, we are just recording or documenting the findings. If we if we are to document the findings, we are to describe what we see lang na. So we don't diagnose it. We use cataract when diagnosing already. So for cataracts, we describe it as having white lens opacity or lens opacity. For your tonometry, it's the intraocular pressure measurement. So your normal would range from 10 to 21 millimeters of mercury, and the standard for examination is by using the Goldman applanation tonometry. It is uh, it is built in with the slit lamp, no? So it goes with our slit lamp already to have it easy access. So for digital tonometry at your level, since you won't be using the slit lamp with the Goldman applanation tonometry when you perform tonometry, no? So you just use your fingers, use your index finger in assessing the the estimate of your patient's IOP. So in estimating for your IOP, the digital tonometry technique, you instruct the patient to look down but not close the eyes. So just the patient just looks down, no? And just ask the patient to look down. Then alternately palpate or indent the globe through the upper eyelid using one index finger. Then feel for the rebound pressure with the other index finger. So normally, uh, it's soft like the tip of your nose. It's abnormal if it's very soft, like it's comparable now with your earlobe or lips. It could mean that the IOP is low. Or if it's very hard or very firm, it's comparable now with your forehead. It could mean that the patient's IOP is high already. So in this picture, the patient's being tested for IOP using the Goldman, no, the Goldman tonometer. This is the gold standard. We check this under the slit lamp. It it is connected, no, the Goldman is connected to the slit lamp, and we usually see this Myers, no, for the proper alignment of the semicircles or the Myers. It should be uh, the inner edges of the semicircles are just touching each other, not far away or not too far from each other, or not like over overlapping, no, just touching lang. So that's when we record, and then we check for the scale here, at what point the patient, at what point we can appreciate the Myers touching each other. So for this one, the pressure is 14. So each line would represent uh, 2 millimeters. So one would be your 10. For the second line, it would be 12. The second, the third is 14, and so forth. So in between, you have your 11, 13. So for your low IOP, when you can feel that the patient's eye is very soft, no? So be careful, since some of our patients, since Soto, if you'll be rotating Soto soon, uh, testing for tonometry is not done if the patient is suspected of a traumatic rupture. No, so if the patient's if the patient will be if the patient the eye is suspected to be ruptured or open, you have to omit performing tonometry, since you could be exacerbating the the trauma, or worse, you can cause the expulsion of the intraocular contents. No, so that's the only time that we consider you not having the tonometry finding for patients with trauma. But for patients in the OPD, like in routine checkups, you perform tonometry, and if you note that the patient's eye is very soft, no, it's like your earlobe or softness sa lips, no, you can suspect for presence of retinal detachment. But for hard or firm, like a forehead, you can suspect presence of glaucoma or high IOP na. For ocular motility testing, we test for the um, six cardinal gazes. No? So we have to instruct the patient to move the eye in all six directions, and we usually use an object for the patient to follow. So we ask the patient to look upward and left, um, upward and right. Ask the patient to look right and left and down, both also for right and left. This directions can test for our muscles, no, corresponding muscles. No? So in that direction, you can check for the superior rectus, the inferior rectus. No? For left and right, you can in left and right gazes, you can check for the lateral rectus and medial rectus respectively. For the inferiors, you can check for the inferior rectus and the superior oblique. And then we indicate if there are restrictions or overactions, no, and then we grade it as 1 to 4. So usually in cases like this, no, there are patients having overactions. No? So from this picture, on primary gaze, the patient looks orthoporic. The patient has corneal light reflex at center. No? But when the patient looks at the right and left gaze, some of the eye overreacts, no, overfunctions. There are overactions. No, so for this left, you record it And also this one, over action siya. So we then record it as +1 if we note 25%, +2 50%, and +3 if 75% overaction, +4 if 100% overaction and we can't see the eye na. Mas puti na siya tanan. And the same is true with restrictions, no? So we also we also grade it 1 to 4 but minus for the restriction. So if the patient's eye totally is not has no movement, then that's the time we say that it's -4. So 100% restriction, no movement at all. Are there questions regarding this? This is an example na there is a -3 na record, and when the patient is looking at the upper up and left na direction. So as you can see, when the patient is looking at that direction, the eye has some the, the eye has some restriction. So we record it as -3. So it's important to check, no, for your EOM, so your ocular motility testing. We usually ask the patient to follow one of our fingers or any target that the patient could follow in all directions of cases. No, so I guess uh, you have touched that topic in your first year. No? So checking for the extraocular motility function. So now let's go to fundoscopy. So you have your fundoscope. The objective for this is to visualize the optic nerve head and the retinal structures in the posterior pole of the fundus. So we usually use this device. No? So this is your ophthalmoscope or your fundoscope. So these are the parts of your ophthalmoscope. First, you have to, in using this one, you have to adjust the dial, no, as to what refractive error you have, no. So you rotate it to the red or to the minus if you are myopic, and to the green if you are hyperopic or farsighted. As an examiner, to see the you have to see the fundus as clear as possible. So we have different types of apertures and filters incorporated in this device. You know, so you can um, adjust the size of your spot, having a small aperture, a large aperture. You can also use an aperture wherein it is calibrated, no, graduated. There's provides graduated crosshairs for measuring eccentric fixation, and also use filters and slit, no, for this. So the technique, if the patient's right eye is being examined, so the doctor also uses the right eye with the use of the right hand. So holding the ophthalmoscope using the right hand, the doctor examines the right eye of the patient using the doctor's right eye also. So right, 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 left, left, left. Uh, so in performing your fundoscopy, you have to set the environment at a dim lit na room or a dark room. So this would increase mydriasis. No, it would help you visualize the fundus more. And also, you have to instruct the patient to look far away to avoid constriction. So if the patient would fixate at a distant object, the the pupil would remain dilated, no, or avoid meiosis. So this is the correct technique in performing the ophthalmoscopy or the fundoscopy. So you assess first for presence of the ROR, red orange reflex, before you get close to the patient, and you also always observe the right, and the left, in order to avoid kissing the patient. No, so para avoid ka kasuhan also for your safety. If the patient has COVID, we avoid performing this one. Or patient has cough, no, you can uh, get the cough. So use your right, then you examine the patient's right eye using your right hand. Always remember that. So first, we elicit the red-orange reflex. So we shine the light of the fundoscope to the patient's dilated pupil. So if there's no ROR, like the picture on the left, no, in presence of very dense lens opacities like the mature cataracts, your light won't get through your retina. No, not it would not give you red orange reflex. No, so there would be no view of the fundus and no chance for you to perform fundoscopy. So if that would be the case, just record it as um, not tested or unable to test due to the dense opacity, dense lens opacity. For the steps, you have to have the patient seated comfortably, and then the room is dimly lit. You turn off the lights, and then instruct the patient to look far at a point, or um, ask the patient to fixate at a distant object. And you set the lens focusing wheel to +8 or 0 depending on preference. And then use appropriate aperture depending on pupil size. No, you can adjust, as I've said earlier, you can adjust the aperture that you are going to use in the fundoscopy. So begin to look at the right eye at 1 to 2 feet from the patient and detect for the ROR, and then place free hand on patient's forehead to aid and keep you steady, and then may use the thumb to hold the eyelids open. And then you slowly come close to the patient at 15-degree temporal to the patient's line of sight. That's observing, or that's maintaining the presence of your ROR. So if by getting closer and then the ROR is being obscured, or the ROR is not already appreciated, no, so you have to come back to that line of sight so that you will be focusing on your patient's fundus. No, so the goal is to maintain the red orange reflex. You have to keep the pupil in view until vessels are seen. So when you come close to the patient, you come close to the patient's eyes, the vessels um, could be appreciated na. Then turn the focusing wheel towards negative direction, or towards the power or fundus image becomes clear. And then you follow the retinal vessels towards the optic disc and examine presence of any abnormalities of the vasculature, or any abnormalities in the retina. Examine the retinal blood vessels, the retinal background, and the macula. And you examine the patient's fovea last, as it is irritating. The light would be very debilitating to the patient. So if you'll be using your ophthalmoscope. It's a very magnified version of your retina. So it's around 15 times zoomed in. So you'll only be seeing a segment of your fundus. So just uh just slowly maneuver your movements so as to follow any certain parts of your posterior pole. This would be this would be excuse me, this would be the picture when you use your slit lamp. No, so in slit lamp examination, we see the fundus in this magnification, but in ophthalmoscopy, it's 15 times magnified. So you'll be expecting this view. So you have to follow the vessels, as I've said earlier, to check for any abnormalities. So it really takes patients to follow any presence of abnormality, since you'll be starting from inferior, then going to superior, and checking for the nerve, then lastly for your fovea at the center of the macula. You have to trace the blood vessels until you see a confluence of vessels, and you observe the optic disc and determine the cup to disc ratio. And lastly, the macula. This is how we usually draw it. No? So for our findings, we use the red for the arteries and the blue for the veins. Then the macula is the one here, and the center of the macula is the fovea. Oh, lisod siya. Lisod yun mag-fundoscopy, no? So it takes a lot of effort and per experience, no, before you can appreciate this. So maybe if uh soon I'll be able to visit you in person, or I'll be able to cover for Doc Martin in person, maybe we'll have to practice performing or I think you'll be having your own demonstration man for this ophthalmoscopy or fundoscopy. No, so you really need to know this step, no, or this skill, since even if you don't go into ophthalmology residency, even if you're not gonna be an ophtha, this is expected. Uh, it's an expected competency. Uh, when you pass the board exam, and you you uh, you practice as a general practitioner, no, this is unexpected, no, and this is unexpected na skill or expected na competency, na you have to perform ophthalmoscopy, direct fundoscopy. You have to record initial findings, no, so presence of ROR, um the the any presence of media opacity, or the state of the media, your disc borders, if it's distinct or indistinct, your or the color of your disc. You have to record the color of your disc, the cup to disc ratio, the AV ratio or the arteriovenous ratio, the hemorrhage, presence of exudates and hemorrhage, or the foveal reflex. No, is if it's good or positive in a foveal reflex, or dull. I can't appreciate the foveal reflex. Now, so for abnormal findings, so you can, if the patient has dense lens opacity that you won't appreciate red orange reflex, then just put negative ROR. Then that's it. You can't have your findings, any other findings na. No? So if you have an ROR expected, you'll be able to check the fundus. No? So you have to complete it, check for the media, the borders, the disc borders, the color of the disc, the disc ratio, the AV ratio, presence of hemorrhage or exudates along the vessels, and the foveal reflex. So, all in all, this is the report that we are expecting you to give, no? And if you rotate in ophthalmology, so we are able to get the patient's VA, record it properly with how usually it's recorded. You draw the adnexal findings, label it properly. You have an estimate of your IOP by doing the digital tonometry. You also draw the extraocular motility function of the patient by checking the patient's gazes, no? Check for any limitations or overactions. And then lastly, your fundus, then check for presence of ROR, the clarity of the media, the disc borders, the AV ratio, the cup to disc ratio, the presence of hemorrhage or exudates, and their foveal reflex. I don't know what this slide. So just a discussion lang on describing your nerve, no? So for describing a healthy optic disc, so this is your central cup, the one that's at the center of the circle, no, of the round of the disc. So can imagine a cup and a saucer. No, so the saucer, the one that's holding the cup, is a disc, and the central cup is the center, and then the rim of nerve tissue is the one in between. The normal would be zero point 0.3 to zero point 0.5, and in abnormal cases, such as in patients with glaucoma, you'll be having or you'll be seeing increased cup to disc ratio around zero point 0.9. Now, there is a large cup in relation to the disc. So we estimate it as zero point 0.9, no, ang ratio sa cup divided by the disc. No, so it's around zero point 0.9. Normally, it's just zero point 0.3 to zero point 0.5. Yellow disc with indistinct disc border. So you can't appreciate the disc borders already as compared to this wherein can delineate the borders, no? There's a round border. Compared to this, there's no definite na border can appreciate. So record it as indistinct disc border. So if you appreciate presence of retinal lesions, check for these lesions, no, presence of hemorrhage, exudates, no, mga microaneurysms, any dots, abnormal na sila. So if you can see any dot inside the eye, it's abnormal. So it's already a microaneurysm. Normally, it's just a sea of orange and the vessels. No other lesions present. Other examples of abnormal optic disc in patients with optic atrophy, instead of having a yellow-orange color of the disc, so you have a pale uh, optic disc. So it's pale yellow na color. For patients with AION or arteritic ischemic na optic neuropathy, um, portions of your a portion of your disc is pale. No, so not all. So for this, there is a superior na pallor or super pallor of the disc. For DM retinopathy, in some cases, your disc would have um, neovascularizations. No? So presence of hemorrhage also on the disc. The nerve is somewhat crowded. There are a lot of neovascularizations present. So for your abnormal retina, you'll have your discussion the next following discussion on eye emergencies. You have to identify the central retinal artery occlusion, no, is one of the ophthalmic emergency. So if you can see a dull colored retina with a cherry red spot, you can think of central retinal artery occlusion. Ideally or normally, the color would be orange, right? So in this picture, it's pale white with a central cherry red spot. No, so it's a central retinal artery occlusion. For CRVO or central retinal vein occlusion, you'll be having your thunder blood or storm and thunder na appearance. It's mixture of your hemorrhage, diffuse hemorrhage, and exudates. For branch, can also have your hemorrhage and exudates, but on a specific area only, like superior quadrant in that area only. So it's only affecting a certain branch of the retina. So branch retinal vein occlusion. For your branch retinal artery occlusion, a portion lang of your retina is edematous, no, or so pale, no. So in this area, in this picture, the inferior. For your DM ret, anything can be observed, like presence of neovascularizations, presence of exudates. So any presence of retinal lesions, think of retinopathy. And if the patient is diabetic, highly likely it's diabetic retinopathy. For the maculopathy, any lesion that can be appreciated inside the macula. So an abnormal macula such as your age-related macular degeneration, you'll be seeing yellow deposits at the macula. Those are your drusen, like this. If you can also see this like round salmon patch na looking lesion, you can think of a macular hole. If you if you see it as like that, when you view it from another perspective, it's like a hole in your retina. Then your wet macular degeneration, you'll be observing intraretinal hemorrhage or blood underneath the macula. So in testing for the Watsky-Allen test slit beam, no, you will be assessing the patient's view on a slit of light. No, for patients with macular hole, since the fovea is already affected, the patient won't see a single slit as a whole. No, the patient would see like it's distorted centrally like this. So if the patient could report to you that the line is not so the patient report that the line is distorted at the center, highly likely also that the patient has a full thickness na macular hole. There are other equipment used to check for the fundus. No? So these are relatively new. We don't have this. We don't have this yet in our OPD. There are already smartphones involved, no, in checking AI, no, checking for the fundus. This is an eye care device that uses an iPhone uh, docked to the device to check for presence of the retinopathies. It could take pictures of your fundus, no, so we don't have this yet. So that ends our discussion this afternoon for the basic eye examinations. Do you have any questions? Do you have any questions? I hope you I hope you have understood the basics of the examination in AFTA, since when you become clerks, no, you'll be performing this on a daily basis. You'll be getting the patient's visual acuity, the patient's adnexa. You'll draw the patient's adnexa, check for patient's tono, and then EOMs and fundus. So if that's clear to you, then you'll have to practice lang. No, we don't expect you to be to be very complete man at first, but if you do this more often, then you'll be master na of this. So the one that was shown earlier, no, katong the picture with the overall report, that's the one that's being sent as a medical legal na assessment. So if you, as I've said, if you won't be into OFTA, if you become doctors pohon, uh, and then you practice at the district hospitals, no, some of your documents would expect you to draw that, or some documents, especially those medical legal assessments, you are expected to give that report. So it's important for you to practice, no, doing or having that report as well. So, kay if you perform if you perform your duties as a doctor, pohon, it's one of the expected competency to be able to record or document any eye findings. Okay, so I hope this lecture has helped you prepare for your in-person rotation pohon when you become junior clerks. If you don't have questions, I guess that would end our discussion this afternoon. Thank you for listening. Can contact Doc Martin if you have question, or I'll just uh, leave you my contacts pod. Okay?
Thank you, Doc.
Thank you,
Thank you,
Doc.
Doc.
Thank you so much,
Okay,
Doc.
Okay, Doc.
okay, thank you guys.
Thank you,
Thank
Doc.
you, Doc.
Thank you, Doc.
Sa on man stop present.